Hello, everyone, and welcome. My name is LaKendria Robinson, and I serve as the Director for Business Connect and Community Outreach for the Tampa Bay Super Bowl 55 Host Committee. On behalf of the Host Committee, NFL Foundation, and NFL Inspired Change, we thank each of you for joining us today for part 2 of Huddle for Change, where we will focus on physical health and racial inequalities. We are thrilled to be partnering with Community Tampa Bay, a leader in creating diverse and inclusive communities through meaningful dialogue and genuine connections. We couldn't be more proud to work with Tammy and her team and all of the things they've done thus far. And we also look forward to remain in lockstep with her and the Community Tampa Bay team as they continue to facilitate these important discussions. So again, thank you so much, Tammy. Thank you to your team, to your board, and all of your supporters for the partnership and the incredible work that you've done. We look forward to seeing what you do next.
Wow, thank you so much, LaKendria. Partnering with the Super Bowl Host Committee has truly been an honor, and working with you is such a joy. Good afternoon, everyone. My name is Tammy Bryant Spratling, and I go by she, her pronouns. It is my honor to serve as the Executive Director of Community Tampa Bay. Community Tampa Bay envisions a community free from all forms of discrimination, where every individual is treated with dignity and respect. We have been creating space for anti-discrimination work as a nonprofit in the Tampa Bay area since the 1940s. We believe that cross-cultural connection and dialogue are essential in breaking down the biases, prejudices, and stereotypes that contribute to systemic discrimination. Therefore, our mission is to cultivate inclusive leaders to change communities through dialogue and cross-cultural interaction. In other words, we empower people with the tools to have hard conversations with others who don't look like them, live like them, or love like them, to create a more equitable community. With the Huddle for Change conversation series, we have the platform to bring together diverse people from across the Tampa Bay community to engage in conversations about individual experiences aligned with the health equity data provided by the Tampa Bay Partnership. We specifically have developed an interactive and facilitated program format to encourage all participants to share their personal experiences and perspectives. Our learning objectives do not stop there, though. We will then take our shared conversations and develop out next steps that we believe can eradicate racial inequalities in Tampa Bay. At the end of this series, we envision having a set of solutions moving forward. For each topic, we will also partner with subject matter experts who are building equity in the community through their work. Today, we are pleased to be partnering with Florida Blue and Reach Up, 2 phenomenal organizations committed to health equity here in the Tampa Bay area. Now I have the pleasure of introducing Dr. Ruth May Sears, who will moderate our panel discussion, Anna Alhoud, who will facilitate our small group discussions, and Dave Sobush, who will provide our data overview. Dr. Ruth May Sears is an associate professor at the University of South Florida. Her research focuses on educational curriculum issues, the development of reasoning and proof skills, clinical experiences in secondary mathematics, and the integration of technology in the teaching and learning of mathematics. Dr. Sears has presented nationally and internationally and has been published in leading mathematical education journals. She coordinates developmental mathematics courses and USF's undergraduate and master's degrees in mathematics education. Anna Alhoud recently joined Community Tampa Bay as its professional education educator. Anna uses her experiences with international education to create safe and welcoming spaces for adult learners in workplace trainings and conversations. Dave Sobush is Director of Policy and Research at the Tampa Bay Partnership. He is an expert in economic development research and project management. In his role at the Tampa Bay Partnership, he leverages a career of project management, data analysis, planning and reporting, and development and implementation of recommendations to enhance prosperity and economic competitiveness throughout the Tampa Bay region. Mr. Sobush is a certified economics developer and has been active with the International Economic Development Council, Florida Economic Development Council, and National Association for Business Economics. Now I'm pleased to turn it over to Dave Sobush for a data overview, who will be followed up with Dr. Sears and the panel discussion, and then Anna will take over to lead our small group discussions. Dave?
Well, thank you so much for that kind introduction. I'm very happy to be here to present some relevant health equity indicators to inform your conversation and your activities this afternoon. I'm Dave Sobush. I'm the Director of Policy and Research with the Tampa Bay Partnership, and I'm pleased to be able to present some information from our State of the Region initiative. The initiative is a collaboration between the Partnership, the USF MUMA College of Business, the United Way Suncoast, and the Community Foundation of Tampa Bay. What we've done together over the past years is to come up with a set of relevant information and indicators to describe how we're doing as a community. And we publish that each year in our regional competitiveness report. In recent months, as you know, we have taken an additional step to examine these indicators from a lens of equity, and that led to our regional equity report released in August last year. I'm going to walk through some relevant health equity indicators. Please feel free to hold on to some questions, and I'll be able to answer those later on in the afternoon. First, we're going to take a look at health insurance coverage. Tampa Bay ranks 16th out of our 20 markets in terms of the number of population that has access to health insurance. At 81.4%, nearly 1 in 5 Tampa Bay residents are without health insurance. When we examine the equity gap for health insurance coverage, we find that Tampa Bay ranks 9th with a 4.7 percentage point difference between white residents and Black residents. Of note, the health insurance coverage rate for white residents is the lowest among the 20 communities examined in the report. Within Tampa Bay, looking at the counties that comprise the Tampa Bay region in our competitiveness report and equity report, we find that Sarasota and Manatee counties have the largest health insurance equity gaps and the lowest rates of coverage for Black residents of those communities. We know that poverty is one of the main determinants of health within a community. And while poverty is not a perfect measure, it's one that we can examine with some regularity and along an equity lens. Tampa Bay ranks 15th out of 20 markets in terms of the share of residents living in poverty, and at 14.1%, its poverty rate matches that of the United States. When we take a look at the poverty gap between Black residents and white residents, we find that the gap ranks 16th out of the 20 markets. And disturbingly, Black residents of Tampa Bay are nearly 2.5 times more likely to live in poverty in comparison to white residents. Within Tampa Bay, we find that Sarasota County has the largest poverty equity gap, where Black residents are 3.5 times more likely to live in poverty. Digital access certainly has become more important both in work and schooling, but also through the delivery of telemedicine. And so it's important to understand how households can access the internet and the services provided through telemedicine. So we take a look at digital access, which is the share of households that have both a dedicated broadband connection as well as a computer. At number 20, Tampa Bay households have the lowest digital access among the comparison regions in the report. 82.5% of households have digital access, meaning 17.5% of households do not. When we take a look at the gap is still relatively low in the comparison set, 18th out of the 20 markets. And of note, both Black households and white households in Tampa Bay rank last among the relevant comparison markets. Within Tampa Bay, and somewhat surprisingly, given their dense population, Pinellas County has the second largest digital access gap. 86% of white households have digital access compared to just above 2/3, 67.2% of Black households. Finally, we need to examine the effect of the current state of affairs, which is relevant in terms of vaccinations. And first, we have some good news. Despite a vaccine rollout that started only in January of this year, Tampa Bay recently vaccinated in its 1 millionth resident, which is a tremendous accomplishment out of roughly 4 million adults. To have 25% of our population vaccinated within 4 months is a tremendous achievement. The results of a recent scientific survey of Tampa Bay residents also shared some concerning outcomes related to the COVID-19 pandemic along the lens of equity. Our Wave 7 survey, the last of our annual series of surveys conducted, was given to the adult population of Tampa Bay on March 31st and April 1st of the past year. And what we found along the lines of that equity lens is that African American residents are more likely to be very concerned about the COVID-19 situation, 42% of African American residents in comparison to 37% of all residents. Also, when asked the question, how likely is it that you will be vaccinated? African American respondents indicated that they are far less likely to get vaccinated. 43% of those residents said, I will not be getting the vaccine, compared to 24% of all residents. Along the lines of ethnicity, we found Hispanic and Latino residents are also more likely to be concerned about the COVID-19 situation. 42% of Hispanic Latino residents compared to 37% of all residents. And when asked, have you received the vaccination? We found that Hispanic and Latino residents are far less likely to have received the vaccination. 71% of Hispanic Latino residents are unvaccinated in comparison to 59% of all residents, again, at the beginning of the past month. And when we dive into the actual numbers that the Department of Health reports, and this is taking a look at the vaccination numbers that have been provided by the Department of Health, divided into an estimate of the adult population for racial and ethnic groups, we find that white residents currently in Tampa Bay are 2 times as likely to be vaccinated compared to residents of either Hispanic origin or our Black residents. 39% of white adults have been vaccinated compared to 17% and 19% of Hispanic and Black adults, respectively. There's a lot of information in a short time. For more resources related to equity measures, the state of our region, the economy as a whole, and the COVID-19 pandemic, you can visit www.stateoftheregion.com. I appreciate your attention, and I'll look forward to participating with you the rest of the afternoon.
Good afternoon. It's truly a pleasure to facilitate this panel with Dr. Kelly Tice-Wells and Ms. Shadleen Apollin, in which they reflect on Dave Soba's report of the state of the region relative to racial equity, particularly impacting the health of the Black and Brown community. Hence, at this time, I invite Dr. Tice-Wells, followed by Ms. Apollin, to really reflect on the data and consider attributes of the report that we should really attend to. Dr. Tice-Wells.
Thank you, and good afternoon, everyone. I'm so glad to have the opportunity to be a part of the discussion today. I can tell you, as a family physician who trained in an inner city setting with the goal of practicing in an underserved area, I'm delighted to see a great deal of this content actually come forward for wide and broad discussion. I currently serve as the Senior Medical Director for Medical Affairs at Florida Blue, and I've held this position for just over a couple of years. A part of my responsibilities is public health surveillance, really being able to leverage what was a 17-year career in the public health system, but also to begin to look at and build out our company's health equity strategy. The newest responsibility that I have grown into has been to serve as clinical lead for our COVID-19 response here at Florida Blue GuideWell. It has been a career that has been really peppered with, if you will, a lot of opportunity to address and reorient the clinical community as well as the public at large about health equity, what it is and what it isn't. And I hope that the dialogue with my co-panelists this afternoon will give us the opportunity to really highlight for folks not only what you should be paying attention to in the Tampa Bay area, but also what you should be paying attention to on a more broad perspective. Thanks for having me.
Good afternoon, everyone. I would like to thank the organization for allowing ReachUp the opportunity to be able to express their reach within the Tampa Bay area, as well as the mission and goals for the organization as a whole. My name is Shedleen Apollon. I am one of the maternal health specialists, a part of the Pregnancy Medical Home Program, which is one of the 7 programs ReachUp offers within the Hillsborough County area. And just to provide you some history, ReachUp began as the Central Hillsborough Federal Healthy Start Program underneath the tutelage of the Lawton and Rhea Child Center located at the University of South Florida. ReachUp since has been officially incorporated and is a 501c3 nonprofit organization. And the mission and goals of ReachUp Incorporated are solely to help communities achieve equality in healthcare and positive health for the entire family unit, whether that be the traditional nuclear family or kinship givers, caregivers, or anyone involved in the raising and upbringing of the family system. And I think ReachUp's primary aim is to build community capacity at improving what racial and ethnic equity looks like, as opposed to equality in healthcare and positive health outcomes for the families in the Tampa Bay region. And just to go over some of the programs we offer, as mentioned, ReachUp did start off as the Central Hillsborough Healthy Start Program, which still remains. There's also the Pregnancy Medical Home, which I am a part of, Nurse Family Partnership, which offers assistance for first-time moms, with focused nurse home visitors who provide support with child development and the span of pregnancy, as well as health and wellness for kinship givers. These are family members who are taking care of children that are not necessarily biologically their birth children. So these are uncles, aunts, grandparents. We also have the doula program, 24/7 DAD, stress management for both staff and community participants, as well as the Stronger with Focused Fathers, which serves at reintegrating the father into the family unit. And I think throughout all of these programs, ReachUp serves to increase equity with health outcomes. And I think this will allow for a great conversation to be had with my co-panelist, Dr. Tice Wells. Thank you for having us.
Thank you. As we reviewed the data, one thing that resonated was nearly 1 in 5 Tampa Bay residents are without health insurance. What are your thoughts when you see these types of statistics? And what could be done to address this disparity?
I can tell you that one of the challenges has long been folks who are uninsured and underinsured as the primary barrier for access to care. The other thing I think that is not spoken about enough is that there are many who have access to insurance but don't know enough about what's available to them to take advantage of it. We are currently, we're involved in a special enrollment period now, and there have been changes made to the marketplace plans that allow access for those that are uninsured, but also allow their monthly premiums to be subsidized. So there are many folks, hopefully within the sound of all of our collective voices, who are eligible for health insurance coverage and simply don't know that it's not as far out of reach as they think. And the big first step that we've got to overcome is that information barrier. With us working on the payer side in terms of being sure that we've got plans that are available and are enrolling new members. But as members of our communities, I think we also have to be sure that the folks who should be receiving that information not only understand that this is happening, but take the additional step of seeing themselves within the information, right? So being aware that there's a special enrollment period is not the same as understanding I may be eligible for affordable coverage, which is, a far different thing. And so, I think how we communicate about what's available is critically important. And that will then allow us to be sure that everyone who's eligible is taking advantage of it and will solve some of the things that drive some of the disparity gaps that we see.
As I looked at the data set, there was also a point that there was racial disparity as well. And they made a note that Tampa Bay's white health insurance coverage rate of 84.7% is lowest among the cohort in comparison to Jacksonville, San Diego, Portland, Phoenix, Baltimore. Can you provide insight into this cost disparity relative to the location where someone is residing?
I actually spent a long time as a health officer and was frankly astonished over and over again at how significant the impact of place is on health. In fact, we published a report at one time that looked at some of the same things that were covered in Dave's presentation. Where it is that you reside can influence your access to care, your access to information, resources, et cetera. I think that having data like this should drive us toward effectively solving that. If that is, as I said in my earlier comments, if that's a health literacy issue, like I'm not certain what health insurance is or how I can take advantage of it, or if that is something more concrete, for instance, a failure to ensure that access to signing up for enrolling in plans is provided equitably among members of a population. I think moving to determine what the root cause of that is has to be our next step so that we can again solve it. When Shedleen was talking about the various programs that ReachUp offers, what I was struck by is there is no catch-all in the list that she's provided. It is very individually focused and needs-based. And I think that as a system, we've got to be sure that from the outset, so as we attempt to solve problems with lack of coverage, we need to think about that from an individual perspective and try to meet our community members where they are in terms of what gaps in information or access they might be experiencing.
Shedleen, do you want to add to that?
Yes, thank you so much. Dr. Tice-Wells actually set up a very good seaway, I guess, into the title ReachUp, the organization. ReachUp actually is an acronym that stands for Respond, Educate, Advocate, and Collaborate for Health in Underserved Populations. So understanding that the dynamic of the family unit, each individual person has individual needs. The way that we may reach mother or the mom during the prenatal phase may be different from the way that we address father, and understanding the dynamic as it changes also from just having a relationship with someone to now becoming a parent with someone. And I think one thing that we ought to examine when speaking about equity is that accessibility is not always equal to availability. Just because something is available to someone does not mean it is accessible. And I think one of the ways that our programs aim to address some of these issues with accessibility is providing this education to our clients about what they do qualify for, what systems are available to them for them to be able to access, to utilize, to be able to increase their outcomes. And we do have a lot of conversations specifically here in the pregnancy medical home about insurance eligibility requirements, as well as what insurance can actually entail for clients. We find out a lot of clients are not aware of just the breadth and the depth of what insurance can offer in the prenatal phase, from doula support to birthing products like breast pumps and things of the like, things that can actually close some of these gaps in health outcomes. So having these conversations and having organizations like ReachUp that are able to actually break down some of these barriers that can be for individuals in regards to what insurance looks like, or what even a doctor's visit, questions to ask at a doctor's visit. These conversations are what are needed in order to progress and close some of these gaps in equity.
I want to extend that comment that you would have made relative situating it, particularly with the disparity that was noted that Sarasota and Manatee have the largest gaps and lowest rate of coverage for Black residents. So how would REACH-UP respond? And also, what advice would you give to other community partners to increase persons of color in seeking medical coverage?
I think one of the largest things is engagement. We know where the communities are, we know which communities are suffering, but there is a lack in engagement with these communities. I think one of the premier ways to address inequity is to involve the community. Sometimes a lot of the efforts that we put out as organizations can sometimes be top down, whereas we're outputting all of these efforts and all of this assistance to the communities, but we're not having conversations with the communities about what they need in order to address their healthcare needs. And fortunately, as mentioned, REACH-UP is very focused in the way that we address our community, the way we collaborate. And I think that collaboration and engagement is going to be what's going to elevate us from where we are right now, and also to close some of these equity gaps, involving the community in their healthcare needs, determining how it works best for them, meeting them where they are, whether that means having community council meetings, which we do hold monthly in the evening, providing resources on the weekends, making it as accessible as possible for this community in order to allow them to have better health outcomes, I think is what I would implore other organizations to institute in their region to lower these problems.
Dr. Wells, you'd like to add to it?
Yes, I would like to add, I think that Shedleen has perhaps made the statement that is the most powerful one of the afternoon, and that is relative to including members of the community in the program development. We've heard the statement made before, I'm certain, nothing for us without us. I think that the ability to really do that effectively can be diminished as we expand our reach across regions, out of the neighborhood, essentially. And so organizations have to be very intentional about maintaining that sort of connection to the community so that it can continue to inform the process. Often, right, it's easier to check the box by saying, our focus group revealed this, or we did a survey and it revealed that. And that is actually very different than what Shedleen describes, hosting community meetings where you get, regular feedback and input from those that are being impacted by the work or the programs. At Florida Blue, the way we try to accomplish that is to charge our teams with doing work at a hyper-local level. So we have teams that are tasked with knowing their local community and understanding the needs, and then being responsible for connecting the pieces of services in order to provide, a comprehensive solution. So things that may be happening from a grant perspective in that particular area versus what the sales agents and sales teams are doing, in addition to what the employer groups may be doing, to give you an example. I think the other thing that we have to be conscious of is in reviewing data like Davis presented, often the individual can still be missed, right? The numbers are certainly concerning, but again, the individual mom, for instance, who is having to push her child, in an umbrella stroller across railroad tracks to get to care and services because there isn't a local bus stop. She may not show up on our survey, right? That may come out in a community conversation and only in that setting.
I want to extend that comment that you would have made relative to the railroad tracks, because poverty is a real phenomena. In fact, the data suggests that Black residents of Tampa Bay are nearly 2.5 times more likely to live in poverty versus their white residents. So how do you account for the racial disparities as it relates to this healthcare as well?
So I'll start. I think that we can't leave a conversation like this one without without saying the real things. Like we need to have real conversations and be ready to have real and complete conversations. And often what we do in this space is we talk about, social determinants of health or drivers of health. And we separate those discussions from racism and racial inequities. And really the reason that there has been the opportunity to do work in the area of social determinants of health for decades, the reason there has been the opportunity for me to change careers, to shift from public health over to the payer sector and still be talking about health disparities and health equity is because we failed to accurately define what drives that. And that is racism and discrimination. Those are the constructs that create the disparity that we see, that keep people in poverty. It is the reason that we have the opportunity at Florida Blue to do work on generational poverty. As a health payer, we are actually looking at specific zip codes around the state where we know people are consistently and systematically disadvantaged from elevating themselves out of a poverty state. That doesn't get solved with a health program, right? That gets solved when we do things like the Tampa Bay Partnership is doing. It begin to have the difficult conversations about racism and how it shows up in our communities and how it impacts the health, not only of individual residents in the community, but the community overall.
Shadleen, you would like to add to it?
I believe Dr. Tice Wells very much gave a beautiful summary of just what the bulk of the problem is. And I think without having those difficult conversations that truly address how systematic and systemic racism has trickled down generationally to affect the outcomes of health even today, the work really cannot begin. It is very important to meet people where they are in the community, to address their everyday immediate needs, because on one hand, conversations about systemic racism don't feed children at night. Conversations about systemic racism do not promote better health outcomes in allowing people to get to doctor's appointments and meeting their needs, their everyday needs. However, not having conversations about systemic racism allows this issue to perpetuate as long as it's had. I think the silver lining of the situation that we're in with the racial uprising across the United States of America, on one hand, is that the conversation is finally being had. However, if we don't come out of this with some actual change, with some outcomes that can actually produce change, we'll remain in this same place and continue to perpetuate this cycle. So, yeah.
Thank you. I want to piggyback on your comment relative to igniting change and catalyzing change. We're in a digital era, and one of the results highlighted that Tampa Bay households have the lowest digital access among the comparison regions. So how do you think we could capitalize on the digital platforms to increase our awareness and our attention to health disparities? And also too, how could we also address this lack of access to the technology as well? What are your thoughts?
I think it begins with education. There is, again, the conversation about what is accessible versus what is available. First, on the availability standpoint, is access to internet usage in the home for private use? Is it accessible? During COVID-19, we've noticed that due to social distancing protocols, many of the public libraries and entities in which to offer internet access to certain individuals who may not have it privately, social distancing protocols has limited that. And we've seen then an uprising in the conversation about how the digital age, or lack of access to digital entities, or the internet rather, is in the home. So are we having conversations about, is it available? Is it affordable even to have a subscription to an internet service or internet provider? And even then, do individuals have devices by which to access the internet? And a lot of individuals have smartphones, and we know that smartphones are very well in the wealth of what they can provide, but a smartphone is not equivalent to a computer, especially when we have a lot of students learning from home. We have a lot of individuals who may be working from home, understanding that that may be a burden in and of itself. But then we also have conversations about even if someone does have access to the internet, and we're especially now in the age of the COVID-19 pandemic, we saw an issue in the beginning with our elderly population not being able to secure appointments for vaccinations, because you can say, yes, there's a hotline, you can say, yes, that there's a website for them to schedule appointments. But do we know the ability of these individuals to be able to do that on their own? So the conversation has to be dual fold when we talk about the digital age. And as much as organizations are very much apt to want to put everything online and join with, moving forward digitally, we have to consider our population. We have to consider who we serve in aiding them with coming along with us as we transition into this new age and this new phase.
Dr. Wells, you'd like to extend?
I would. I love everything that you said, Shalyn, and I think that it's our approach. You have rapidly become my person, right? Those of us who have done work like this, I hear what you're saying, and it resonates with me in such a significant way. I've added you to my list of resources, but I think the foundation of the problem is that if our solution to a thing does not begin with those who may have a barrier in mind, then the output will only do what it's been intended to do. Meaning if we solve for the middle, right? We put it online, most folks, then we don't even see as a part of the development process, about the implementation process, we don't see who's been missed, right? They show up other ways in, case rates that continue to rise in those communities, ER rates that don't go down, right? They show up other ways. And so, I think we have this opportunity, those of us, again, who have done work like this, and I have said, and I put my colleagues on notice, and thankfully I have the support of a wonderful CEO in Pat Garrity. I've said the door is open, and shame on us if we don't walk through it. Now that we've got the attention of thought leaders and force multipliers and researchers and advocates and businesses, we need to really support all of those folks in revamping how they approach solving problems like this, right? I can't see a problem without first thinking, who is left off the list, who's not at the table, who isn't represented, right? And how do we incorporate their needs into this solution? When in fact, that is not the typical way that most entities begin program development or problem solving. And that's the crux of it, right? We can talk about, we're talking about digital access at the moment, and we can build a plan that understands or creates a space for someone with limited, Wi-Fi access at home, and smart devices that may have limited minutes, or that sort of thing. I think we can define the guardrails if we're talking about digital access. But really, anything that we know to have an impact upon health, we have to solution it in a way that's intentional. And it starts with, how is this service issue access provided? And then what groups are disadvantaged? And then you solve for these groups, right? Because everyone with privilege, has access, right? If you solve it for this group, you've solved it for everyone else. And so I really would like to have us focus going forward on how we approach solution versus the learning of the data, which works in the interim. But I'm sure there's a barrier out there that we have not identified yet that is, working equally as well at keeping folks out of care and impacting their health.
Thank you, Dr. Wells. You made a very good point, because you're highlighting a need for us to attend to the socio-spatial differences. And this came out in the results where they highlighted Pinellas has the second largest digital access gap. And so as we think about this disparity for different spaces, do you consider different recommendations that you see based on your own personal observation relative to the Tampa Bay area that you see can be implemented immediately? So Dr. Wells or Shadleen?
Well, if I could, I'll jump in. I think that one of the things that's happening in the healthcare community at large, and certainly that we are exploring in the payer space, is leveraging digital solutions to help manage chronic disease, for instance. And everyone's got a product, a tool, a system, a company that is working in that space and, can be used to solve it for, the majority of the population. But I think what I would suggest is that we explore leveraging things like that, telehealth, for instance, leveraging that intentionally to expand our networks. And for example, there are some communities, Pinellas may be one, but certainly there are other more rural communities that are disadvantaged and under-resourced, and any access to care requires a significant amount of travel, that sort of thing. What if, even in households where digital access wasn't, average, what if we partnered and provided that access at a brick and mortar site in county, but use telehealth to allow residents in that community to gain access? Now, does it substitute for in-person care? No, it does not. But we've proven in our pandemic response that there is a role that virtual health visits can play in chronic disease management, in health education. I'd like to see us leverage it in a way that does a bit more than advance the technology itself, but actually solves the right now problems of community members who don't know how they're going to get to their next doctor's visit.
And just to piggyback off of what Dr. Tice-Wells mentioned, I think one recommendation I would give to organizations in over the topic that we're discussing is to utilize community organizations like that of Reach Up. We are under the leadership of our wonderful president, Estrelila Loberry, and the leadership team that we have here at Reach Up. Our mission and aim is to advocate for and mobilize resources to get these resources to the community. And Ms. Loberry is one of the most profound voices in this arena when we're talking about health equity in the Tampa Bay region, utilizing organizations like that of Reach Up and our similar sister organizations who provide these resources to have these conversations to help eliminate these disparities by not only allowing us to connect you with community members, community leaders who may be able to sit at these tables and help achieve these goals, but also to extend the conversation further. Dr. Tice-Wells mentioned earlier about how data sometimes can limit us, whereas community organizations that deal with the people on a day-to-day basis have these qualitative experiences that are profound and that exceed what the data can show. And in data, and I'm pretty sure everyone on the call this afternoon is familiar with the scope of data, and Dr. Tice-Wells did an excellent job at explaining how sometimes the data can be centralized to where those outliers and those individuals who may not fall within that catchment are not able to be addressed. And I think when you use mixed method approach and not just stick with quantitative data, but use the voices of the individuals whom you're aiming to serve, I think then we're able to expand and extend the conversation past what those solutions that can kind of fall short in addressing the needs of the individuals. And I think one last thing I would implore for organizations in actual practical solution is to invite a community leader. We have so many goals that we're trying to achieve as organizations, so many metrics that we're trying to meet. But I think if these metrics do not truly address, and I mentioned this earlier, if these metrics do not truly address the needs of the individual, then the metrics are pointless, to be quite frank with you. And throughout all of the Reach Up programs, we have former program participants or even current program participants that either sit on a leadership committee or sit on the board for the planning of the program. And in that way, our programs are able to be relevant. They're able to continue to be relevant and also continue to serve the populations that we aim to reach. And I think through incorporating those two solutions, I think not only can the conversation continue, but actual equitable work can begin.
Okay, thank you, Shadlin. I wanted to really reflect on very good points that was being highlighted by you and Dr. Wells relative to amplifying the community partners, reflecting on how data is used. Considering one of the findings highlighted that African Americans and Latinos were very concerned about COVID-19 and they were less likely to be vaccinated compared to their white counterparts, what advice would you give to the community to address this disparity and also help close equity gaps relative to health in the Tampa Bay area?
Okay. So I'm grateful for that question, actually, because Reach Up has just instituted a new initiative entitled We Care. And the entire premise of that initiative is to address these concerns. We've held several conversations with the community, albeit virtually, but we were also able to fortunately have a socially distanced town hall, if not last week, I'm assuming the week prior, where individuals were able to just come and ask questions. We've been fortunate enough to partner with the USF Tenasia College of Pharmacy and the dean over there, Dr. Kevin Sneed, who's been able to provide that scientific background on what the vaccines entail, side effects, and just really addressing those one-on-one individual questions that the community members may have. We've been fortunate enough to see an increase in at least interest in wanting to receive the vaccine. And we also have some individuals who have decided to move forward and receive the vaccine. So again, we talk about practical solutions for practical problems, and having these conversations has not only calmed some of the fears of our Black and Brown community members, but allowing the partnership that has occurred between Reach Up and the USF College of Pharmacy that has allowed us not only to bring the people, but bring the people to the science, bring people to the facts, because it's more than just alleviating concerns with, oh, I got the vaccine, you should get it too, but giving them real hard scientific facts to assist them with making their decision. And I think in that regard, Reach Up has been able to serve in this pandemic realm that we're in right now.
Yes, thanks. You know, I think the Shedlene touched on the approach. I think that we have to acknowledge that that if folks have a low confidence in the vaccine, that it's our responsibility to engage them in a manner that allows them to have their confidence be raised. And you know, I said very early on that in many cases we needed to be prepared for it to take multiple conversations. And in fact, when I talk about work at a hyper local level, you know, seeing something on your evening news is quite different than engaging with a physician, a pharmacist, or other you know, clinical leader who may be similar to you in terms of race and ethnicity, and who can share one-on-one their thoughts about the safety and effectiveness of a vaccine. I think it's being willing to host those conversations and then being thoughtful about the choice of experts that are involved in those conversations, so that the community again feels like the information resonates with them because it's coming from a trusted resource. That's a tool that we have utilized across the state, just kind of setting up these pop-up vaccine locations. You know, using the data to identify areas that are under vaccinated, but then partnering with someone in the community, right, to solve that. You know, it's not Florida Blue to the rescue. It is, in fact, how can we highlight community partners like Reach Up that are already doing the work, and we just get to shine a spotlight on them and support, you know, events that you may be hosting, or, you know, provide a speaker or that sort of thing. So love that model. And I think it is that repetitive cycle of community conversations that's going to help folks gain confidence in accepting vaccine.
Pardon me, sorry, I wanted to make a correction. The previous focus group, well, the previous conversation about the vaccine was not in person as of yet. We're planning on doing something socially distanced in the future. It was still a video call. So I just wanted to make correction to that.
Thank you, Shedlene. So at this time, I'm going to invite you to bring closing remarks that really helps to provide insight into systemic practices and policies that could be implemented to address the racial disparities and inequities relative to healthcare in the Tampa Bay region. So I'm going to ask Dr. Tice Wells, followed by Shedlene, to bring concluding remarks.
Great, thank you. And thank you so much for facilitating our conversation today. I think that there are a few points that we've advanced that are worth noting. And one is, is to start from the point of solution building at identifying your target groups and determining how you're going to incorporate them into your problem solving. COVID-19 has brought with it a number of lessons, and it has done in a really catastrophic way a good job of identifying for us clearly where disparities exist. It is our responsibility now to put that learning into use. As we are tracking the populations that are identified in the data that we've reviewed today, as we're tracking them going forward, we need to recognize that those are the communities likeliest to be impacted by COVID-19, both the long-term complications from it, delayed access to care and treatment, as well as the other impacts such as failure from an educational perspective to advance, which we know directly correlates to an ability to be financially independent in the future. It's those communities of color that are at greatest risk. And so we must keep our eyes on those communities and recognize, as we are tracking and solving some of those issues in the larger majority community populations, we need to ensure that the same set of services and solutions are provided to these communities. The problem has now been declared. Now it's up to us to adjust how we solve it so that we can stop revisiting these conversations year over year.
And just to echo, I want to thank Ms. Sears for facilitating our conversation, the invitation for me to serve as a representative for Reach Up Incorporated, as well as the wealth of information that was shared here this afternoon. But I think the one thing that I would like to add to what Dr. Tice-Wells has said is, now that we've established the problem has long been established. It's time to act, it's time to move, it's time to provide driven solutions based on what not only the data has informed us of, but the voices of the community. And I would be remiss to not re-emphasize this point and drive this point home. We Reach Up, and I will speak for myself as a public health practitioner, are nothing without the people. And in our work, in the day-to-day things that we do, we must incorporate the voices of our people. These communities have long been marginalized, have long been underserved, have long been underaddressed. And part of that reason is because they're not invited to these tables, to these conversations. And even in your interpersonal relationships with individuals, allowing those around you, those Black and brown bodies, those Black and brown people, to use their voice, to amplify their voices, is going to be the way that we get out of this. But also on the institutional level, on the organizational level, it is imperative that we invite these members of the community to the conversation, because equitable work cannot begin if access is not allowed. Thank you.
Thank you. It was truly a pleasure to hear your perspective of ways to address racial disparities and health inequities in the Tampa Bay area. I'm confident that we work collaboratively, change is possible, and we can definitely achieve health excellence in the Tampa Bay area. Thank you all. Have a great day.
Hello, everyone, and thank you for joining today's program. Thank you so much to Dr. Sears, Dr. Wells, and Ms. Apollon for your insightful comments and recommendations for progress in this issue. Your conversation allows for us to make deep connections between the data Dave Sobush showed us and the important work you are doing in the community related to physical health equity. As a way of encouraging even more connections to this issue, we are now going to move into small group discussions led by Community Tampa Bay trained facilitators. We hope that all our participants will use this time to engage in meaningful conversations that add to our individual and collective understandings of racial health equity and our roles in promoting it. In a moment, our tech team will send us to 5 breakout rooms where we will get to know each other a bit more and answer 4 questions that relate to the themes that we've touched on so far. Everyone is encouraged to keep their camera on and contribute to these discussions as they feel comfortable. Our fantastic facilitators will help guide these conversations while taking notes for our large group share out to be had a little later. You will have 30 minutes to discuss before we all return back to this meeting space. Any further questions can be directed to your facilitators. Without any further ado, let's get started. See you all in 30 minutes. Welcome back, everyone. All of our breakout rooms have now closed and we are back together, joined in one community. I hope that you all had meaningful conversations and were able to begin envisioning solutions developed from your unique experiences. Now, we are going to outline our collective solutions and report any significant highlights that occurred during the breakout groups. I will call on each facilitator to share a summary of their group's discussion as we collectively reflect and build next action steps. As the facilitators give their reports, please consider these two questions and provide any answers you might have in the chat. The first question is, what are some next steps forward for the community? And the second question is, which critical voices and perspectives need to be included? So on this collective and inclusive train, I'm going to go to our first group, which was facilitated by Manolo and Lena.
Sorry, I needed to unmute. Hi, my name is Manolo. I use he, him, his pronouns. So on the first question about what we can do to go about building trust within the community, we really talked about how we can't go in with a preconceived plan, right? We have to go in without that expectation, so we know exactly what the needs are of the community, and then we can build a plan based off the needs. Because if we had a plan before, you know, it's not going to meet the needs because it's not what we've heard from them. And then trust is also really important, and to build with family, right? So we want to build trust within family members, maybe health insurance providers or medical providers aren't going to be that person to give that information to different individuals, but family members can. So if we can reach out, then people within the community can go ahead and reach out as well to their own family members that are going to be, they're going to trust them more with that sort of information because they have that closer relationship. And we've also talked about building that bond, building that foundation. Maybe upon first contact, we're not going to have a really sturdy relationship, but if we keep meeting up, if we keep having discussions, we can really build a foundation that can last a long time.
Absolutely. I love that your group really focused on this building block of trust. You know, we kind of ask ourselves, well, how do we get someone to trust us or a community to trust us? But it comes kind of from this element of understanding, which I kind of got from your, explanations of how the family unit ties in and how we can kind of all be a part of this system that isn't just the insurance companies or the medical providers that we turn to. It's really also very much on the ground and the people that we feel safe with. Am I getting that kind of correct?
Yes.
Excellent. I love those reflections. Thank you. And Lena, would you like to add anything else?
Manolo really hit our group perfectly. I think something that we always centered was seeing how community members are already doing the work. This is something that our panelists talked about really beautifully. And kind of leading off with that is something that I think everyone in our group kind of shared some really personal experiences. So I want to thank our group members for doing that and being open in that moment. But also thinking about how we can center our house without centering, the insurance companies or the creators of these medical, devices and supplies, and really centering how we can do that and how communities can be centered first. So Manolo is perfect, and I'm excited to hear what the other groups have to say as well.
Excellent. Thank you, Manolo and Lena, for your excellent reflections and your group's reflections on how we can more utilize trust and understanding and our community connections as a way to progress our medical health system so that it's equitable for all. Thank you. Now we're moving on to our next group, which was facilitated by Monteleo and Liz. Hello.
Awesome, thanks. And just so I'm clear, we are following up on which two questions? Because I want to make sure I get this right.
Oh, absolutely. So basically, out of the 4 questions that we had, it's not a determinant that everyone has to get to the same questions, but basically whatever questions really resonated with your groups and what highlights and reflections came out from there.
Yeah, for sure. So I think our group was really unique in the idea that we were small but mighty because we all 4 knew each other already. So that was perfect. And so we kind of really jumped right into what was going on, and then like this idea of action and kind of how we wanted to move forward. So the first part of it was focusing on these barriers and the differences of like, what are we seeing and how can we interrupt these barriers, and also looking at it from a bigger, larger perspective with the idea of trust. So one of the things that was mentioned in the group is like, is it a systemic thing or is it like a one-on-one thing? And I remember one of the group members also saying like, hey, you know, trust is something that takes time to develop, but also it is something that needs to be developed amongst organizations as well. So I think that really stuck out to me because it was like, well, if you don't have trust amongst each organization, how can you have trust amongst the people in the community to trust that organization?
Absolutely.
Exactly. And so many of our solutions that we chatted about had to do with cultivating accessible channels of communication to build trust and to also interrupt those barriers that we were talking about. And so how do we get the right communication to the right folks at the right time and the right places? And knowing that that is so much more nuanced than, you know, that simple statement, making sure it's in the right languages, that there are folks who are seeking out the communities who are not always able to answer a call, who may not have been in a place to get the call. And so how do we cultivate those channels of communication effectively to build trust, to build knowledge, and to empower folks to be more participatory in their healthcare?
Definitely. Wow. I really, really love what you're bringing up here in terms of, I mean, there's still the, you know, mutual understanding and trust factor that we heard from with Manola and Lena, but we are also exploring this other element of trust. We always think about trust between people, but you're right. We are within these systems that, for better or worse, we depend on for some, you know, to some extent. And yeah, really looking at how our ways of communication can influence that and also enhance that. Kind of going back to what was said in the panel with Shedleen and Dr. Wells, kind of looking at, okay, I think it was Dr. Wells that said this, we're at the door, right? And shame on us if we don't walk through it. And that is such an excellent quote. And I think it ties in directly to what you both are saying and what your group kind of came up with here in terms of, okay, great, we've got the picture. How do we move forward? And how do we move forward in the right way? I think that's the part that's sticking out to me a lot. Excellent. Excellent. And can I just ask one more thing for the considerations of, you had mentioned identifying barriers. Was there any kind of discussion about that too? Because I think about now what you're saying about communication and things like that. So I guess it's just another level of analysis too that we can look at. And maybe that came up in your group as well, of how to identify barriers without first connecting with those communities.
Yeah, I think a lot of it was reaching out to people where they are, you know, because so many times the decisions are made by the small group of folks in a room with power separate from, you know, the folks who need the answers to those solutions. So reaching out to people at neighborhood levels was like a large part of our conversation, finding them where they are, whether that be geographically, linguistically. And then we also talked a lot about the barrier that is the economy of time. And when we think about navigating the healthcare system, you know, am I prepared to sit on hold for an hour? Am I prepared to have to talk to 5 different people and tell them my story before I get to the right person who can help me? Do I have to take a day off of work in order to do that? And then when that narrative circulates the community of how challenging it was to access that care, you know, then that's an additional barrier of, well, now the reputation is such, or the narrative is such that I don't even think it's feasible for me.
If I can add one more thing, I think just to really echo what Liz said about the physical aspect. So we always talk about the idea of meeting people where they are. So like meeting somebody where they are mentally, emotionally. But I think when we talk about this, it's literally meeting people where they are physically. So I'm going to step into that space. I'm going to ask, can I bring myself into this space to offer what you need in this time and meet you where you are? So I'm going to ask, can I come into your community to provide the services that you need? So I'm going to bring that access to you. Instead of saying, well, I have the building over here, come and find me. Like, come to my door and come through the door. I don't want to do that. I want to come into your space after I've asked, can I come into your space? And while in your space, I want to provide those services to you.
Absolutely. And I think it's touching on this more intimate or deeper connections that our health providers and our health institutions could have with people. I think especially with insurance, it's kind of a murky field that everyone is kind of afraid, not sure about all the details, but you need it. And I feel that that is also a barrier that kind of ties into what you all are saying, which is that, we definitely have to, it can't be a show. It can't be, oh yeah, we care for you if you go X, Y, and Z, and if you pay X, Y, and Z. But we care for you as a community, and the community requires trust, it requires understanding, and it does require communication. So thank you both. Thank you, Montalea and Liz, and your group as well. Excellent. And just to put it out there for everyone who are all of our participants, we are utilizing our chat. I see it blowing up right here. So thank you. Please continue that excellent feedback and energy as we continue into our next group, which was facilitated by Valentina.
All right. Hi, everyone. My name is Valentina Montoya. My pronouns are she, her, hers. And in my group, we echoed a lot of the same things mentioned by the other group. We did focus a lot about barriers and what that looks like in these different communities, and how you can really notice these barriers simply by looking at the geographical locations of supermarkets and how easily accessible groceries and the health of food is in these neighborhoods. And how there might be more gas stations in one and just fast food options rather than groceries and organic foods and something to home cook meals. And so we talked about those kinds of barriers in food that connect to health. And aside from that, we really wanted to focus on solutions, right? And how we can maybe find a way to create change in some manner. And we talked about free clinics and how, although those are options that people have available, they're not the most salvageable for everybody. They don't always work because they're not fit to work 24/7. And some people will not be able to make it to these clinics, or they're not providing the services that people need. And so a great idea that was highlighted within our group was this idea of home visits and having people come to you and finding you where you're at and helping maintain that sense of stability within your family and within your home and feeling safe and secure, while also providing still that necessary change and the health that you need. And another really, really great idea that our team came up with is this idea of having like one big medical reunion, I would say, within big corporations that are able to help. So like sports arenas or college campuses, and providing services like eye doctors and medical examiners. And maybe if you need a haircut too, that's part of staying emotionally and healthy. And so having all of those available in one site in different areas of a city to help support that community.
I love that. I'm blown away actually by these solutions, because they're touching deeply on what's been talked about in the panel, as well as what was reflected in the data. How does accessibility actually play out? I love the examples that you all mentioned of of identifying barriers, such as the supermarkets, what's around you, how are you getting your nourishment? Because, as we know, health isn't just that trip to the doctor, it's all the days and weeks and years before that trip to the doctor. I'm also really liking the second solution that you mentioned about having community centers. Was there any further discussion about that, or how that would look like? And because that's very interesting.
Yeah, so my great teammates in our group were talking about how these programs sort of already exist. And one example was veteran programs. They have sort of similar areas that are set up for them, where they have the eye doctors and they have their physicians and they have the cardiologists and all that happening in one center. And for us, that looked more of like a traveling center that's not held all in one day, but spread out throughout a month, throughout a few months, whatever it may look like, in different locations, so that they can be accessible to these communities that would not commonly be accessible to.
Excellent. Excellent. I really appreciate the way your group focused on not only just identifying, but really responding to the challenges that exist for people that aren't able to get to the care that they need. And I think that's also a very good point that you brought up before as well about the urgent care. I feel like this has been kind of framed sometimes as a cure-all, you know, a panacea, like, all right, now we got urgent care, that's fine. But it's true, depending on your condition or your circumstances in general, it may not be that that's the best choice for you. And if that's the case, we do have to step up as a community and as a society to make sure everyone's getting what they need. Thank you very much, Valentina. Moving right on to our fourth group, which was facilitated by Jasmine. Hi, Jasmine.
Hello, my name is Jasmine and I use she, her pronouns. We had a great discussion in our group, and I think there are definitely some similarities with what the other groups were discussing. And one of the things we did also really touch on were those barriers and the uniqueness of those barriers within individual communities and the variance that they have. Something that we brought up was how much we need to kind of consider what different individual communities need, and specifically even just smaller neighborhoods, and how we can't really have the easy blanket approach to racial equity, especially with healthcare as well as other needs. And so some of the barriers we touched on were things like access to transportation, where institutions are located, where the specialists are located, and how that's going to impact community members, but also even barriers within the healthcare that people are experiencing. So how different coverage will give you different experiences with different providers, and what barrier that creates for people, and how that discourages some and creates the issue of trust again when it comes to receiving healthcare. And so one of the steps we were discussing in relation to those barriers and understanding them was, again, what we were discussing earlier. How do we understand individual communities? We have to engage in those communities, in the spaces where we can best engage with them in. If the community values religious leaders or religious spaces, how do we engage in those spaces? How do we connect with them in those spaces? So same for other kinds of spaces. What is going to be accessible? Do we provide healthcare access in schools, community centers? What is going to be truly accessible for the community and also relevant for that specific community?
Excellent. I really appreciate that detail that your group kind of focused on of not every community is the same. And you could have a community of the same type of ethnicity or nationality or whatever it may be, and that is going to look different, what they respond to and what is also going to work for them. Thank you for bringing those two very important topics up. I think these are great nuances that are adding to our growing understanding of this theme and how we all play a part in it. Thank you. Thank you very much, Jasmine. Wonderful. And wrapping up with our last group, which was facilitated by Danielle.
Hello.
Hello.
So great to hear from everyone. It's always this interesting thing to be the last one and to try and bring something new to the conversation. So I'm going to try my best to do that, y'all. But yeah, I think a lot of especially the conversation of going to people and physically going to people was something that did come up in our conversation. But what I really appreciated about the conversation that I had with my team is we really took the time to think of this on a personal level, and we did reflect a lot about how our different identities may affect the experiences we're able to have. And somebody who had mentioned that they had more privilege talked to the fact that if they don't like a doctor, they can choose another doctor, and the ability to have choice in a system. I think there's this difference of when I'm able to have access, or like I say, I have health insurance, or these things are there, but as Jasmine mentioned, what is it that's exactly available to me? I might have limited choices, limited options, and to have more choice and freedom to be able to choose somebody that you are able to feel is going to better understand your situation is important. And so what I really loved is as we spoke, my participants used a lot of action solution-based conversation about when we go into communities, making sure we're not going into communities making assumptions about them and how they operate and who they are. Go in, start asking questions and hearing from them to know what it is that their needs are, and let them be the ones to help to lead change in the things that are most needed when it comes to their health or any form or things that we're trying to change. And that it has to start with building relationships, and people getting to have those relationships are able to feel like they have autonomy in being able to access the things that they need, or maybe have a voice to change the things that are not going so well. Our group had a little bit of a like personal community support session right in the middle of the conversation. And it was good because it also really reminds me it's important to share stories and create vulnerability to connect to people, especially that may not have had the same access and abilities. And somebody who is very, I literally had two like mamas in my room. It was great that spoke to their experience and helped even me in my thinking and my understanding to help understand, oh, this is very important for me and I need to prioritize this. So having that vulnerability, having sharing your story and connecting to spur others to act is also important.
Oh, absolutely. All the snaps for your group and for all the groups here, because I really feel that this has been the perfect way to also kind of end off our discussion, looking at the psychological and the emotional responses that come too from, not being able to choose the doctor that you want, or to go to someone who you feel that you can trust in. And trust also comes into play when we talk about sharing our own experiences, like how you mentioned. But thankfully, through events like this, and also through the opportunities that we get in our lives, our professional lives, our familial lives, all of it, to be able to share with people that we feel comfortable with, and that we trust and that feel understand us. So thank you for adding to this discussion about how important all those elements are. It's not just one, it's not just trust, it's not just understanding, it's not just feeling that you have a choice, it's everything wrapped up under the lens of, okay, what's best for the community, not necessarily for the provider who's giving it. Absolutely. Thank you so much, Danielle. Excellent, excellent. And with that is all of our groups. Just big snaps for everyone who participated today. Thank you all so much. And thank you to our facilitators. We really do appreciate your emotional work in this and the way that everyone has expressed the importance of this theme, which is making sure that we are in an equitable sphere and society for everyone of our community to be able to trust in their medical institutions and in the care that they're able to have, not just by looking at data, but also looking at that data and our experiences as one to make sure that we're looking at as much as we can. So thank you all very much. This program has been especially energizing, and I hope that you all feel the same. Thank you all for your engagement in today's small group discussions. We are going to take the information shared here today, as I saw mentioned in the chat, as well as everything you added in the chat to compile a set of next steps and solutions in combating physical health inequity in our community. I am pleased we've had this opportunity to unite in the name of promoting equal and fair access to medical care that everyone deserves. Together, we take a look at Tampa Bay Partnership's health equity data and began to compare our unique experiences and perspectives on the panel and in our groups. We then shared next possible steps and solutions that we can work toward as committed members of the community. We intend to use today's feedback from today's event to guide our format and substance for next time. So at this moment, I'd like everyone to please turn your attention to the chat. Our wonderful partner, the University of South Florida, created a survey for you to provide feedback on today's program. Please find this link in the survey and please feel free to use it. Any feedback is good feedback. Thank you so much for this feedback. That will help us in preparing the future of the series. We would also like to thank all of our speakers and facilitators for their time and investment in today's program. We would not be able to hold this event without the support of our community partners, the Tampa Bay Partnership and the University of South Florida, as well as our physical health equity partners, Florida Blue and Reach Up. I'd also like to give a special thank you to our facilitators. Thank you for being so adaptable and so ready to engage us in these conversations that we definitely need to be having. Please feel free to stay engaged with the work of our partners and Community Tampa Bay through our websites and social media platforms. Until our next Huddle for Change event on August 12th, there are plenty of opportunities for you to support the impactful initiatives that Community Tampa Bay engages in throughout the year. This month, for instance, we'll be holding our annual Transformations fundraiser, which will be held virtually on May 6th from 4 to 5 p.m. You can find the registration link in the chat right now. Thank you, tech team. And for participants who are interested in our successful multi-year Anytown program, you can find information about our summer youth seminars and opportunities for volunteering in June and July by accessing the link that's also been shared in the chat. We hope that you will join us for the next program in our Huddle for Change conversation series, where we'll be focusing on mental health. Please save the date. It is August 12th, 2021. Finally, we would like to thank all of you for your sharing, vulnerability, and vision in how to develop a more equitable Tampa Bay together. We hope you too are inspired to continue creating meaningful movement toward a more equitable and inclusive community. Thank you once again for your support, and we look forward to seeing you next time. Until then, stay safe and stay inclusive. Have a good evening.